Hi there, this is Barbara Garcia back with Intrarenal Disorders, Chapter 27 for Path 370. All right, so what are intrarenal disorders? Obviously something within the kidney, as opposed to things that affect the kidney, filtration and things of that nature, right? So these are actual physical problems with the kidney, right, that result in renal insufficiency or renal failure. All right, so some of the categories for intrarenal disorders include congenital, and I want you to remember what congenital means, right? So congenital means that you are born with it, not that it is genetic, just that it's something that you are born with. Can it be genetic? Yes, it could be genetic, but not all genetic things are congenital. All right, so neoplastic, which means from a cancer origin, could be infectious, it could be obstructive, or it could be glomerular. So specifically affecting the glomerulus, which you know is the place where filtration occurs. So you're definitely going to have some problems with filtration, and thus you're going to have a filtrate that is not the way it's supposed to be. All right, so pain, right? So one of the common manifestations of kidney disease is pain, right? So we call that nephralgia, right? Mostly felt at the costovertebral angle, so where the ribs meet the vertebra, right? And it's recorded usually as CVA, costovertebral angle tenderness, or flank pain. Right? It's usually due to some sort of inflammation, distension of the renal capsule. Remember, the renal capsule is a connective tissue that surrounds the kidney, and it has a dull but constant type of manifestation of pain. Okay, pain is transmitted by T10 to L1 and by the sympathetic afferent neurons, right? And so maybe felt throughout the dermatomes that of the area where that is specifically innervating. Right, so you can see here, this is T10, T11, T12, and L1. So anywhere around there is the dermatomes that may be affected by kidney disease. Right, so obviously if there is a filtration problem, then you're going to have urinalysis findings that are abnormal. Okay, so usually abnormal urinalysis findings let us know that there's some type of renal dysfunction, right? So you may have a dipstick test where you take urine and you take a little dipstick, and it has some things that it can check for, like pH, it can check for glucose and so on. And then there's other types of urinalysis findings that may be you're looking under the microscope, looking at crystal, also appreciating the translucency, right? If it's cloudy, for example, it could give us an infectious process, or if it's very dark colored, right, it could indicate, and strong smelling could indicate a decreased renal function, right? So all of these can provide some clues as to what's going on internally. All right, so a kidney, ureter, bladder radiograph, so that's a type of radiograph that's specific for that region of the body, right? Identifies any type of gross abnormalities related to the size of your kidney's position and shape, right? Some because calculi, right, renal stones, right, kidney stones are not translucent, they're actually opaque in nature. They may also show those in an x-ray, right? Renograms or renal scans can show us the vasculature and any tumors that might exist within the kidney. Ultrasonography, right, can differentiate some tissue characteristics, and a CT MRI can also give us more detailed information about the vasculature and the tissue of the kidney, right? So a patient has pain upon light palpation over the costovertebral angle. Which term should the nurse use to describe this finding, right? So remember that is not dermatome, renal colic pain, flank pain, or hematuria. I'm sorry, it is flank pain. It is not hematuria. Remember, anything that ends in uria, like letter D here, is going to be something present in the urine, right? So hema refers to blood, so hematuria means there's urine in the blood. All right, so renal, right, some congenital abnormalities include agenesis, where the kidneys don't develop normally, right? So clearly, if you have bilateral agenesis, this is not compatible with life, because obviously we must filter our blood. And it will probably not provide sufficient time for you to get the fact that you don't have a functional kidney does not provide you with sufficient time, you know, in development to get a transplant, right? So one-sided unilateral agenesis, right, can occur and can be seen, and usually will compensate with the functional kidney. So the functional kidney will hypertrophy. Remember, the word hypertrophy means that the cells of that kidney get larger, so that kidney gets larger, right? So some hypoplasia, right, in fetal kidney development can lead to end-stage renal failure, which means hypoplasia means low development, right? Low creation of new cells. So obviously that can cause to have a kidney that is non-functional, right? Really, you don't need both kidneys. One kidney can maintain a normal renal function, right? But clearly, if you have only one kidney, you're going to be monitored very carefully to make sure that that kidney is functioning adequately. All right, so cystic kidney diseases are also congenital, right? It's often genetic, and it is transmitted, where you see a very enlarged kidneys with fluid-filled cysts. They can disrupt urine formation and flow, and can affect one or both kidneys. This cystic type of kidney disorder usually will lead to renal failure, requiring dialysis and eventually transplantation. You have two types. There's autosomal recessive and autosomal dominant. Remember, autosomal dominant means that you only need one defective gene in order to get it, which means you probably have a parent that has the disorder. Clearly, the disorder is not lethal because they were able to live long enough to pass it down to their children. So an autosomal dominant disorder that has nothing to do with this, but is one of our best examples of an autosomal dominant disorder, is Huntington's disease, right? Which is a nervous system disorder, and is passed down usually seen in every generation. An autosomal recessive form, however, is usually skipping a generation because you need to have both genes be defective in order for you to get the disorder, right? So you can see here, this is a normal kidney, right? Kidneys are about the size of a bar of soap. I want you to appreciate that if the one on the left is the size of a bar of soap, the one on the right is probably closer to the size of a football. And yes, these cystic kidneys, we also call them polycystic kidneys, are extremely enlarged, very, very large. All right, so the autosomal recessive is evident at birth. Kidneys are enlarged. You might see respiratory distress or palpable kidneys on physical examination because they are so large, right? Severe systemic hypertension, liver problems. It is found on chromosome 6p. And just to let you know that the P means that it's the short arm of chromosome 6. Chromosome 6 has a short arm and has a long arm. The short arm is petite, so P for petite. And then the long arm is the letter that follows P, which is Q. Sorry, I didn't make that up. That's just how it is. Okay, so inheritance pattern can help you know if this is the cause for the cystic kidney, whether it be autosomal recessive or dominant, and then obviously paired with a liver biopsy, right? So autosomal dominant are the most common, so not autosomal recessive. Autosomal recessive are quite severe, right? The autosomal dominant types, remember, just like I mentioned before, you're going to have a disorder in which the person has lived long enough in order to have children. So you'll see most of these symptoms actually arise the older that somebody gets. There's two types. There's one on chromosome 16 and one on chromosome 4, right? So eventually what you'll see is reduction of intracellular calcium, excessive concentrations of intracellular cyclic AMP, right? So the normal function of the kidney, yes, these kidneys can function normally, but is slowly reduced throughout life. And so at as it gets slower, eventually it's going to affect the functionality of the kidney, right? So the kidney now becomes no longer functional. Then you'll see round cysts, kind of in that picture like you saw, of varying sizes, and then other organs around it may also develop cysts, especially the liver, right? So in a decreased ability to concentrate urine, hypertension, pain, and cystic liver involvement are many of the clinical manifestations that you'll see in an autosomal dominant polycystic kidney disorder. Again, genetic history, remember, autosomal dominant usually does not skip a generation. It is usually found in the parent, in one of the two parents, because you only need one dominant, right? One dominant gene in order to pass it down to your children. Okay, so one parent usually has it. A primarily supportive, right? Controlling blood pressure, any other pathologies that might be associated. Usually at end stage renal disease, that treatment plan will include dialysis. All right, so neoplasms, right? So we have benign renal neoplasms, right? Many types of non-metastasizing growths that might be found in the kidney. Some, symptoms of these types of neoplasms depend on the size. So the more, the larger, right, they are, the more they can affect the surrounding tissue. Remember, benign means that it is not going to metastasize. Does not mean that it does not affect the function. If it gets large enough, it could affect the function and affect the function of things around it because it is very, very large. Okay. You'll see a palpable abdominal mass, and then hematuria and flank pain. So a renal ultrasound or CT scan leads you to a diagnosis of the disorder. Right, so then the treatment is nephrectomy, so removal of the kidney, right? Usually can be done laparoscopically and with a lot of tissue sparing procedures in more recently. Another type is renal cell carcinoma, which is a metastatic disease, right? So there may be familial patterns, so there may be some family history, right? And then some risk factors include smoking, obesity, and hypertension. It is often asymptomatic until it is quite advanced. So again, CVA tenderness, right? Hematuria, palpable mass. You have a staging system as you do with many tumors and cancer, a 1 to 4 staging system, 4 being the worst, right? And then the treatment is nephrectomy. And if it is metastasized, then radiation to immunotherapy and chemotherapy. Sometimes it could be resistant to radiation, immunotherapy, and chemotherapy treatments. So you can see there the tumor with a capsule around it. That would be stage 1. Stage 2, where the tumor invades the perirenal fat. There is usually fat padding around all of your kidneys. Stage 3, right, where the tumor will extend into the renal vein or other lymphatics. And then, of course, stage 4, where it has metastasized to other locations, including bone, right, the liver, the heart, and the lungs. As you can see here, those are the most common areas of metastasis. Another neoplasm, very common in children, is called Wilms tumor, right? It is definitely a palpable abdominal mass, is most of the time how this Wilms tumor, nephroblastoma, is often identified, right? Children will have abdominal mass, hypertension, and hematuria. And nephrectomy, radiation therapy, and chemotherapy are the treatments, and there is an excellent cure rate for this type of nephroblastoma called Wilms tumor. All right, so infection is another mechanism that can cause an intrarenal disorder, right? So you might see, normal protective mechanisms against infection include acidic pH, right? Presence of urea in the urine, right? In men, there's bacteriostatic prostatic secretions, right? So something that stops the growth of bacteria. Doesn't kill bacteria, it just stops the growth. That's what bacteriostatic means, right? And then women in their urethra also secrete some mucus, right? Micturition, which is urination, washes out pathogens. And unidirectional urine flow, so that there's very little urine that kind of moves upward, right? Prevents reflux. In infection, we might call it pyelonephritis. Usually it's an ascending infection that's ascending from the lower urinary tract, right? So most effective prevention measure is early removal of catheters. And you'll see that many of your infection preventionists in hospitals will monitor how long a patient has been catheterized, so that as soon as the catheter is no longer needed, that person has been removed off of the catheter to prevent infection. All right, so you can see here a hematologist, right? So ascending infection first, sorry. Most commonly E. coli, Proteus, or Enterobacter, and then eventually it can, see, due to this reflux moving upward, right, it can reach the kidney, right, and then we're going to have a kidney infection. Then you may also have a hematogenous infection, so that you have an infection that came from the blood, and it is now making its way to the kidney, and that's mostly Staphylococcus or E. coli infections. All right, so acute pyelonephritis, right, infection of the renal pelvis or renal parenchyma, usually from an ascending urinary tract infection. Most common risk factor is pregnancy, right? In pregnancy, you'll see that even though there's a lot of urine flow, which should prevent that, there is also a deviation of your ureters. And so because there's deviation of your ureters due to the enlarged uterus, you're going to see that that's going to affect the flow, and sometimes you'll get reflux, which can cause pyelonephritis. All right, so CVA tenderness accompanied by fever, chills, anorexia, and increases dehydration. All right, urosepsis, right? So organisms in the bloodstream starting or originating from the urinary tract. So diagnosis is any type of white blood cell cast, which is sort of like a crystal, but not in the form of a crystal. It is like a, it could be either waxy, kind of remnant of the white blood cell. Yes? Waxy or fatty type of remnant. Right? So that indicates an upper urinary tract infection. Right? So that means there was a lot of white blood cells in that area, and they were then going to be kind of broken down by the fact that they had to go through the ureter and the bladder and the urethra. So promptly managed with antimicrobial to avoid any damage to the renal function. All right, so blank is a common finding in the urinalysis of a person with acute pyelonephritis, right? So A is decreased specific gravity, B is glucose, C is protein, D is white blood cell casts. So we just discussed that. The white blood cell cast is very common in people with acute pyelonephritis. So you can also get chronic pyelonephritis, right, which is often seen, right, concomitant with chronic kidney disease. So you can see that chronic pyelonephritis can even lead to chronic kidney disease, right? So associated with reflux of some obstructive process, right, leads to urine that is stationary or urine stasis. So chronic inflammation can also cause scarring throughout the ureter, and then eventually loss of functional nephrons as it ascends, right? So then some of the clinical manifestations are going to be abdominal and flank pain, fever, malaise, and anorexia. Diagnosis of chronic pyelonephritis is via renal imaging, right? So then the treatment, of course, is correcting and the underlying process, and if it's causing like a ureter is being kinked, and that's what's causing stasis and causing the ascending urinary tract infection, or also being very specific in the antimicrobial therapy, maybe testing for resistant and sensitivity of different antimicrobials. Obstruction. Okay, so this is a really important one, right? So conditions that interfere with the flow of urine may be congenital, right? With children who are born with such obstructions, perhaps kinks in their ureters, which can happen, or it could be acquired as an adult. So changes resulting from the location and degree of obstruction. So you may have a partial obstruction and now becomes complete, or it is unilateral and now becomes bilateral. And then you'll also see the duration, acute versus chronic, and timing of the obstruction. All right, so urine stasis, right? So that most obstructive processes are going to cause stagnant urine, right? So anything that's stagnant then of course is going to predispose to things like infection and structural damage. So if the urine can't get out, then you're going to have damage, right? So obstruction could be, think about it, like prostatic hypertrophy. If a male who has a prostate, right, that is enlarged, that means that the prostatic urethra is going to have an obstruction. And so the urine kind of makes its way up. So in a gentleman with a prostatic hypertrophy, they will have the urge to urinate, but then when they go to urinate, they will have very little urine come out. And it's almost like a struggle to get that urine out. It could even be painful, right? So tumors could do the same thing. Kidney stones can do the same thing, right? And some strictures of the ureters or the urethra can also cause an obstruction with an ascending, infection that could then lead to damage in the kidney, right? So strictures of the ureters, right, is not as uncommon as you would think, particularly in patients who may have lost the adequate ligaments that keep their kidneys where they are, and the fat padding that keeps the kidneys in the proper location. So if they lose this fat padding, which can be seen in truck drivers. Okay, so truck drivers, so think about sitting in a truck for about 10 hours a day, sometimes more, because you know that they're sometimes driving more than that. The vibration of the chair, right? So it could even be a bus driver as well, right? The vibration of the chair, right, because of the engine, is going to slowly kind of melt away the fat. And they get what we call like a dropped kidney, right? And their kidney drops because the fat padding around it is no longer keeping it in the right place. And so because your kidney drops, your ureter is now kinked. And that could cause strictures, okay? So you can see here some causes of obstructions, right? So renal calculi, right? So a ureteropelvic stricture or tumor, right? Intrinsic in the ureter calculi tumors, clots, right? Could be even crystal clots or calculi, parts of the calculus that may have come off, and sloughed papillae, right? Or inflammation. And some intrinsic ones like pregnancy pushing up against it, or tumors pushing up against it, retroperitoneal fibrosis, right? Vesical ureteral reflux going up through that little opening, and then some bladder calculi tumors or functionality like neurogenic, if you have a damage to the nerve that causes contraction of the bladder. Right, prostatic hyperplasia, right, or carcinoma or prostatitis, and urethra, any type of stricture or tumor, which is quite rare. All right, so complete obstruction results in what we call hydronephrosis. So the kidney basically enlarges with fluid, right? There's obviously a decreased GFR, because if you have, just like in the heart, it's sort of like an afterload, right? So if the pressure is so great because there's an obstruction, it's going to go all the way back through the nephron, and the glomerulus is not going to be able to filter. Where's everything going to go if there's an obstruction? Right. So ischemic kidney damage, right, because of increased intraluminal pressure, right? That is very possible, right? Consequence. Acute tubular necrosis, because of course now you have limited blood flow to this area because of enlargement, right? And that can lead to acute renal failure, or acute kidney injury, as we will call it from now on, and then chronic kidney disease. All right, so renal calculi, nephrolithiasis. I want you to know that when you see the word litho always means there's a stone. So you might see, you know, cholelithiasis as well, which would be gallbladder stones, okay? So these crystal aggregates are composed of organic and sometimes inorganic materials. So I want you to think of something like a phosphate, remember, is PO4 2-, and a calcium, which is Ca2+. The 2+ and the 2-, they like each other. And as you know, calcium and phosphate make a crystal because we have that all over our bodies in the form of a skeleton. But anything that can basically have a anion meet with a cation, particularly, you know, those like carbonates, sulfates, and phosphates, those are going to make organic crystals, okay? Or inorganic crystals, excuse me. Organic crystals would be made out of anything with carbon, right? So along the urinary tract. So if you make those crystals, then, well, I mean, most of us make crystals, okay? Because we probably will have a balance of our electrolytes that may be off, and we could make crystals. But as long as they're not really large crystals, you're drinking an adequate amount of water, it helps the flow of the movement through there, right? But if you are dehydrated, right, then you are going to have, and you're going to see that there's going to be a greater likelihood of stone formation, right? Because your urine is more concentrated. When you have supersaturation, right, you're going to form stones, okay? And so solute supersaturation, so too much of that solute like calcium and phosphate, low urine volume, and an abnormal urine pH leads to right, creation of renal stones. Right, so most stones are composed of some type of calcium crystals. You might also see uric acid, struvite, cysteine, and other stones associated with certain medications. And yes, there are pictures, and yes, they are very different in terms of the type of stone that they form. So your microbiology lab, right, those labs, those medical labs, can usually tell the difference between one type of crystal and another. They have very characteristic appearances, right? So stationary stones are usually asymptomatic, but the stones, as they migrate, they can cause an intense pain, right? And radiating pain. Diaphoresis, which is, you know, excessive sweating, is common. Even hematuria might be present. So most stones pass spontaneously, but if they don't, they can be diagnosed with a CT scan. And one of the best ways to treat is increasing fluid intake to pass the stone, if that's possible, or if not, lithotripsy or other endoscopic procedures. We'll use a lot of lasers nowadays to try to break apart the stone. Right, ureteral stenting might also be utilized, right, especially if this is a chronic problem or a problem that's happened before. A ureteroscopy sometimes is also necessary and can also help enlarge the area, the ureter, that is. The pain medications are often needed because it is quite painful, and stones tend to reoccur. So one of the main ways is to maintain a high fluid intake, right? So the more dilute the urine is, the less likely it is for you to make more of those stones. And if you know the type of stone that you have, maybe you can avoid these types of anions or cations in your diet, and so that would prevent the reformation of stones. All right, so which person is most prone to develop nephrolithiasis, right? One with dehydration, that sounds good, an exercise routine, right? I don't know, but exercise routine requires a lot of fluid intake, so that one's not so good. Hypotension, right? So low blood pressure, maybe, but usually we're talking about the pressure now in the ureters. So remember that our glomerular filtration rate is very, very maintained. So even unless your blood pressure is really low, that's usually not going to be the best answer. A nephroblastoma. While a nephroblastoma can cause an obstruction, most likely nephrolithiasis is caused by dehydration. All right, glomerular disorders, right? So also called glomerulopathies, right? That's a good word, right? Alter glomerular capillary structure and function. We have quite a few glomerular disorders, right? So this is sometimes mediated by an immune or autoimmune disorder, right? So an autoimmune disorder that attacks the actual cells that line the glomerulus, right? Or an inflammatory process. So, of course, any type of autoimmune disorder could have a hereditary basis, right? It could also be infectious, though, metabolic, right? Even hemodynamic, right? And it could be as a result of either toxicity or injury. And again, genetic. It's obvious, very common. All right, so classifications. Glomerular disorders can be divided into those that are only affecting the kidney, which call primary, and then those that are secondary, right? So they're resulting from other diseases or medications or conditions like Goodpasture syndrome, systemic lupus erythematosus, or SLE, right? We just call it lupus, and in diabetic nephropathy. So remember nephropathy, right? It is your pathology of your nephron or nephro, which usually means kidney, okay, to be more specific. Okay, so this is not a neuropathy, it's nephropathy, which is again is kind of, you know, in the same stage, a person with advanced diabetes, right? So the effect is diffuse, right? Which means all glomeruli are affected, or it could be focal, some but not all, global, affecting all parts of the glomerulus, or segmental, with only specific parts or patches of the glomerulus being affected. Membranous, right, which is thickening of the walls, or sclerotic, which means that we are now getting scarring. Right, so the sites of deposition, the mesangial cells, the cells kind of in between that are going to function in contraction, right? They could be subendothelial or subepithelial, okay? May result in some combination of hematuria, proteinuria, abnormal casts in the urine, right? Decreased GFR, edema, and hypertension, right? So the most common clinical manifestation of some type of glomerular disorder is protein in the urine, right? So proteinuria. Remember, proteins are really, really big. Proteins should not be in your urine. Very rarely do you even have amino acids, which are the building blocks of your proteins, be in your urine. Okay, because usually they are reabsorbed at the proximal convoluted tubule. So the fact that you have proteins, like multiple amino acid proteins in the urine, is quite disturbing. And albuminuria would be probably the most common protein that you'll find from the plasma in the urine. Nephrotic syndrome is specifically characterized by protein loss that is greater than normal, so 3 to 3.5 grams in 24 hours. Nephritic syndrome is also a reflection of glomerular inflammation, but has very mild to moderate proteinuria. So you might see hematuria and red blood cell casts present in the sediment, remember, in the urine. Glomerular nephritis, right? So you're going to have immune response to a variety of potential triggers that produce inflammation of the glomerulus. So you can have primary or secondary etiology and are more common in men. So some of them include acute glomerulonephritis, right? So this is an immune response, right, of a type of trigger that is going to cause immune cells, right, to the area of inflammation, causing lysosomal degradation of the basement membrane. If you remember, the basement membrane is part of your glomerular membrane, right? So glomerular filtration rate then falls because of a contraction of the mesangial cells, which are smooth muscle cells, right, resulting in decreased surface area for filtration. And so that's acute glomerulonephritis. So our clinical manifestations include proteinuria, oliguria, azotemia, edema, and hypertension. Remember, azotemia means that you have an increased blood urea nitrogen or increase of waste products building up in your blood. Could be very dangerous. Waste products in your blood. We need them out. Okay? And that's the reason why they're waste products. Right? So treatments including steroids to lower, right, the inflammation. Plasmapheresis, if it is an autoimmune disorder, plasmapheresis can help us bind out those antibodies that may be attacking the glomerulus, right? Supportive measures such as dietary and fluid management. So sometimes these might require, IV hydration, and management of systemic and renal hypertension. Okay, so you might need to give them medication to help with that. Right, so post-infectious acute glomerulonephritis is the most well known, right? It follows some skin or throat infections. Impetigo, for example, is one of those, right? And it's not very commonly seen here in this country, but it's most common in developing countries, right? And it's common in children, and smoky or coffee-colored urine is what you look for in acute glomerulonephritis. Right, so these throat infections and skin infections are very common in children, and so the care is supportive. Another type of acute glomerulonephritis is IgA nephropathy, which is also called Berger disease, right? And it's most commonly diagnosed in adults, right? It's the most commonly diagnosed acute glomerulonephritic type of syndrome, right? Upper respiratory or gastrointestinal viral infections. And then hematuria is present in 1 to 2 days. And the prognosis is variable and thus may lead to end-stage renal disease. So the prognosis for this type of IgA nephropathy could be pretty bad. Crescentic glomerulonephritis, right? Also used to be called rapidly progressive glomerulonephritis, so RPGN, right? Because the lesions are crescent shaped, right? So it's usually a complication of some type of acute or subacute infection, either drug exposure or some sort of primary disorder, like an absence of systemic, in the absence of systemic disease, right? An acute onset, you'll see with hematuria, proteinuria, and red cell casts, followed by a swift decline in renal functions within 6 months. So Goodpasture syndrome is the autoimmune disorder where you have antibodies in the blood, right, that are basically going to attack the glomerulus, right? So it's basically glomerulonephritis with alveolar hemorrhage, antiglomerular basement membrane antibodies. Okay, so those antibodies, right, are going to attack the basement membrane of the glomerulus. So you might see shortness of breath and hemoptysis as two very common clinical manifestations. And the treatment is plasmapheresis. Remember, this is autoimmune, so you have antibodies, and plasmapheresis is a way for you to decrease the number of circulating antibodies. And corticosteroids to decrease the inflammation, and immunosuppression. So you might see the use of prednisone for that type of, any type of autoimmune disorder. All right, so chronic glomerulonephritis, right? So basically is progressing from a acute glomerulonephritis and developing into end-stage renal disease, right? So there's a lot of sclerosis and fibrosis of the kidney. It is usually seen with proteinuria and with or without hematuria and a renal function that is slowly declining, right? So supportive interventions, dialysis is going to be necessary at the end of this, or kidney transplantation if available and necessary. I mean, it is necessary, but if available. Nephrotic syndrome, right? So the nephrotic syndrome causes a glomerulus to be much more permeable to proteins. So what you'll see is a huge loss of protein, much more than it's supposed to be, right? So hypoalbuminemia, which is low albumin in the blood because it's being, right, filtered and eventually eliminated, right? You might see a generalized edema, which you absolutely should know why, since you have low protein in the blood, you're going to have edema in your capillaries, right, of the rest of your body, right? And then decreased blood colloid osmotic pressure is a reason for your edema. Increased activity of the liver can cause hyperlipidemia and hypercoagulability, and the most common finding is edema. Nephrotic syndrome, so you're going to see here the flow of nephrotic syndrome, okay, and kind of follow that, and you'll see that it's going to start off with proteinuria and lead to edema. And then nephrotic syndrome, the treatment is conservative management like diuretics, lipid lowering agents, antihypertensive, immunosuppression and immunomodulation, and management of underlying process, which is has been identified. May resolve spontaneously, but some also can progress into end-stage renal disease, right? And then minimal change disease, right, is also called lipoid nephrosis. You might see alterations in the glomerular podocytes. Remember, the podocytes are the cells that also provide part of the membrane of the glomerular, the filtration membrane, excuse me, right? So they fuse together, right? Occurs in children, right? You might see edema and nephrotic levels of protein loss and hypoalbuminemia, but this responds very well to corticosteroids. Okay, so I believe this ends chapter 27, and I'll get you guys over in chapter 28.